here I've been given an assignment to talk to you about a little bit of controversial question which were asked in the previous year's INI CET and NEET exams. So I've selected 20 questions out of a bundle of so many questions, which I feel were a little difficult to answer at first, and I would like to discuss those questions with you. If you have got any doubts, you are very much welcome to connect with me anytime, either on WhatsApp or on Instagram or even on Telegram groups. Actually, I have not been able to answer a few queries on Telegram of lately because I was having some problem in the Telegram app in my phone. I tried to reinstall it multiple times, but still the problem is still persisting. I don't know what's the issue. I'm not able to see any new messages in Telegram. But as soon as the problem is rectified, I'll be answering those queries also. All right. So without wasting much time, let's start with the first question. So the question was, all of the following are horizontal buttresses except. Now, what are buttresses? Buttresses basically the buttresses are basically the what do you call the just a sec. Okay, so buttresses are basically the strong bone which is formed along the bony trabeculae so that the forces from the mastication are transmitted to the base of the skull. So once the patient bites, the forces are delivered onto the maxilla and the mandible. So the nature has devised this in a way that the biting forces do not cause any much trouble to the surrounding structures and to the base of the skull. So the biting force is transmitted equally along the base of the skull. So that is done with buttresses. So if we have got horizontal buttresses and we have got vertical buttresses. Now the question asks, which of the following are horizontal buttresses except. You have to highlight this word except. Right? So options are frontonasal, infraorbital, zygomaticomaxillary, and lesser wing of sphenoid. So the answer is quite straightforward. It's a memory based question basically. So you have to write down the answer as zygomaticomaxillary buttress. Now just to give you a brief knowledge about that, this is what I was talking about. The patient bites here. So the biting forces are transmitted along the base of the skull and they are dissipated basically so that the base of the skull does not undergo any injury, right? So that is done with the help of buttresses, and that is done according to the law of bone transformation, which was put forth by Wolff's law of bone transformation. Okay. So these are the transverse buttresses. Transverse means horizontal buttresses. We have got frontal bar, upper transverse, lower transverse, upper transverse, and lower transverse mandibular. Vertical buttresses, we have got lateral maxillary, that is also known as zygomaticomaxillary buttress. Medial maxillary, also known as nasomaxillary buttress. Posterior maxillary, also known as pterygomaxillary buttress. And finally, we have posterior mandible, that is called vertical mandibular buttress. Right? So the answer was option number C in the first question. Now coming to the next MCQ, this is also pretty straightforward. Match the following. Now what the question is asking, we have to analyze the question, what the question is asking here. So the question is asking, in this particular table, here different types of analysis are given, cephalometric analysis, and in the second column, we are asked that which analysis uses what mandibular plane, right? So we have to match the correct sequence. Now, Steiner's analysis, we have discussed that in my previous lectures, in my recorded lectures, as well as in my live sessions also, that the three types of analysis given in the UG curriculum, although there are n number of analysis, we have got McNamara analysis, we have got Harwood analysis, Ricketts analysis, George-Jarabek analysis, Sassoon analysis, quadrilateral, you name it, there are n number of analysis to be read. But for UG curriculum, for your NEET exams, we have got basically three analysis which you need to remember properly. That is Steiner's analysis, Downs and Tweed's cephalometric analysis. And as I said, all these three analyses use different types of mandibular plane for analysis. So we have to match the following. So we know Steiner's analysis uses gonion, nathion as the mandibular plane. The Downs analysis uses gonion, menton as the mandibular plane. And Tweed's analysis uses the tangent to the lower border of the mandible as the mandibular plane. Now, according to this, we have to match the following. We have to pick up the right option. Now, we have 1B, 2C and 3A. So, we are left with option number A. That is the correct option to this question. Okay. Now, just to give you a brief introduction about this, we'll be talking about various cephalometric planes used in the cephalometric analysis. So, we have got vertical plane, we have got horizontal planes, horizontal reference planes rather. Horizontal reference planes, what are all those? We have got Sella to Nasion plane, we have got Bolton plane. Bolton plane is from the point Bolton's point to the Nasion. Then we have got Frank point horizontal plane, we have got parietal plane. FHP is from where to where? From porion to the infraorbital, that is also known as orbital. Then parietal plane is from the PNS to the ANS, that is also known as nasal floor. Then we have got occlusal plane. Occlusal planes are of two types, functional occlusal plane and anatomical occlusal plane. I hope you remember that. Then we have got mandibular reference plane, and this is what the question was about, right? Then we have got y-axis, also known as growth axis. So these are the horizontal reference planes. Now what about vertical reference planes? Vertical reference planes, as the name suggests, they run in the vertical orientation. So we have got facial plane. Facial plane runs from nasion to pogonion. That is specifically used in the Downs analysis. Okay. Then after facial plane, we have got ramal plane. Ramal plane runs along the tangent to the posterior border of the ramus of the mandible. Then we have got AB plane. As the name suggests, it runs from point A to point B. Okay, so these three are the main vertical reference plane, and rest of the planes were the horizontal reference planes. Right. So this is what we have discussed. In Tweed's analysis, we have got mandibular plane as a tangent to the lower border of the mandible. In Steiner's analysis, we have got mandibular plane as a line joining gonion and nathion, and for Downs analysis, the line joining gonion to menton. So you have to remember this. This is a direct question, and this is a scoring question as well. Okay. Third question. Now the question asks, arrange the bracket placement steps in the correct sequence. Now the question is asking about what are the steps involved in direct bonding of the orthodontic brackets to the tooth surface. Right. So this is a pretty simple question. So let's see what are the options here. Options are etching of the tooth, polishing of the tooth, priming, removal of excess material, and finally the bracket placement. Now if you think about it, you can answer this very easily actually. So first is we have to go for polishing of the tooth using a pumice powder. Right. First is polishing of the tooth. After that, we need to etch the tooth using 37% phosphoric acid. Right. After etching, we have to prime the tooth. That is application of bonding agent. You have to apply the bonding agent on the etched surface of the tooth. After etching, I skipped one step. After etching, you have to wash the etchant using running water at least for 10 seconds, and then you have to air dry it so that we have a frosty appearance of the enamel. Once we obtain that, then we apply the coat of bonding agent, a single coat of bonding agent, and light cure it in a very light manner. After that we will place the bracket. We'll apply the composite on the bracket base, and then we'll position the bracket onto the tooth surface properly. And finally, we'll remove the excess material, that is known as removal of flash. Flash is removed. Finally, when you are satisfied that the bracket placement is according to the norms, according to the anatomy contour of the tooth, once you are satisfied with that, then finally we light cure the brackets on all the four surfaces. That's how the bracket placement is. Right? So let's see what should be the correct sequence. So first is option number 2. This is number 1. Right? Then we have option number 1. That is second step. Then option number 3, this is the third step. Then option number 5 is the fourth step, and option number 4 is the fifth step. So we have 2, 1, 3, 4 and 5. So option B is the correct answer of the among the given options. Is it clear? It's quite a simple question. Just have to apply a little brain in this, Alright. So the next question is asking which of the following is correct. We have which of the following statements is correct. Now let's see what the question is asking. Facial index is face height from nasion to nathion upon bizygomatic width into 100. So you know what is facial index? I have discussed about this earlier also. So this is what is called the facial index. If you look at the skull in the front, or if you look at the face, if you are looking at the skull, that is called as craniometric analysis, and if you are looking at a live person, that is called anthropometric analysis, right? So in this diagram we are talking about craniometric analysis because this is dealing with dried skulls. So facial index is the facial height that is taken from the nasion to the nathion or nasion to the menton, right? And finally we have bizygomatic width. This is the bizygomatic width. So facial index is facial height upon bizygomatic width multiplied by 100. It is expressed as a percentage value. That's why we have to multiply the value with 100 if it is expressed in a percentage value, right? That is the facial index. Now the next statement is normal facial index value is 84 to 88%. This is right. So option first is right, option second is right. The normal facial index is, the normal facial type is mesoprosopic. We have got euryprosopic, mesoprosopic, leptoprosopic. These are the three basic facial types based on the facial indices. So the normal facial index that is most commonly seen in the population, that is mesoprosopic. It ranges from 84 to 88%. Long face index is euryprosopic. This statement is false because long face is known as leptoprosopic. So we can eliminate this third statement. And mouth breather of long face. Actually the option should have been the long face is presented in a mouth breather patient. So this is also right, although the language of the statement is not right, but we get the idea ki what the statement is about. So the fourth statement is also right. Now select the correct answer from the code given below. What is it? So we have option A, option B and option D are correct, whereas option C is incorrect. So we have got A, B and D. So out of the 4 options, we have got 3 correct answers. That is option A, option B and option D. Okay. So that forms option B as a correct answer to this question. Right. So as I was talking about, facial index is morphological facial height upon bizygomatic width multiplied by 100. We have got hypereuriprosopic, euryprosopic, mesoprosopic, lepto and hyperleptoprosopic. These are the basic facial types. This is again the same thing I have mentioned in this particular slide. Now similar to facial index, there is something called cephalic index. This is also done in the live individual as well as in a dead individual. Like that means we can go for a craniometric analysis or an anthropometric analysis for measuring the cephalic index. In this what we do, we take the maximum skull width, that means point X to point Y upon point A to point B. That is maximum skull width upon maximum skull length. We should make the patient sit on a dental chair and we should stand behind the patient and do the measurements. Alright. So according to cephalic index, we can again divide the head into different types. We have ultradolichocephalic, hyperdolichocephalic, dolichocephalic, mesocephalic, brachycephalic, hyperbrachycephalic and ultra hyperbrachycephalic, right? Ultra brachycephalic is the widest of the heads available, whereas ultra dolichocephalic is the narrowest of the heads present in the population. Although these are quite rare to occur, these can occur only when the patient is suffering from some congenital developmental anomalies, like you can say some syndromes, right? So you don't see such kind of situation in a normal population on a day-to-day basis. They are very peculiar cases, they are very specific cases, and they can be present only in patients having certain syndromes like Krausen syndrome and even other syndromes which involve craniosynostosis. We have Krausen syndrome, we have Apert syndrome, we have Carpenter syndrome, and the like, right? Okay. Now the next question: what does the outer circle of Venn symbolic diagram represent? Please pay attention here. It is talking about outer circle. This is quite a tricky one. That's why I have purposefully included this question in today's discussion. The question is specifically asking about outer circle. It's not outer square. Okay, it's not outer square. Had the question been talking about outer square, then we would have had a different answer. But the question is asking about outer circle of a Venn symbolic diagram. Now, what is a Venn symbolic diagram? It was given by Ackerman and Profit. I hope you know this. This is one of the most exhaustive type of classification of malocclusion to be published till date, because this encompasses the malocclusion in all three planes of space, in the vertical plane, sagittal plane, as well as in the transverse plane. Now Ackerman and Profit had represented the different types of malocclusion in this diagram. That means as you go from outside to inside of this diagram, as you go centripetally, right? Centripetal is from outside to inside. Centrifugal is from inside to outside, right? Now, as you go from outside to inside, the severity of malocclusion increases. So this is the significance of this Venn diagram. This is what I wanted to specify here. Now the question asks, the outermost circle in the Venn diagram represents what? Now you know this is the outermost circle. Hence, we have profile. We have profile, which can be convex, straight, or concave. And if we talk about the divergence, we can have anterior divergence and the posterior divergence, which can be seen in the patient. And this is given in the outermost circle of the Venn diagram. If the question had asked outermost square, this is the square within which different circles are inculcated. If the question is asked about outermost square, we would have intra-arch alignment and symmetry as the right answer. Right? This is the right answer for square, and this is the right answer for circle. So we have, not option A, it should be option D. This is for circle, right? So the profile is what is denoted by the outermost circle in a Venn diagram. Is it clear? This is quite a tricky one. You have to mark the question, you have to mark the language of the question properly. Alright, so next question. All of the following are proven methods of accelerating orthodontic tooth movement, except, again the question is asking except. That means there has to be only one option which is not a proven method of accelerating tooth movement. Now let's see what are the options. We have got POW. POW is periodontally accelerated osteogenic orthodontics, also known as Wilcodontics. It was given by two people, Wilco and Wilco. They were two brothers who postulated this technique. That's why the technique was named after them, known as Wilcodontics. Now this is a proven method of accelerating tooth movement. Okay. Then second option is injecting platelet-rich fibrin. Third option is corticotomy and injecting parathormone. Now corticotomy is a proven method. Injecting parathormone is also a proven method. Why? because parathormone, if you're injecting in a local environment within the jaws, it can accelerate resorption of the bones, right? So whenever any orthodontic forces are given to the tooth by means of orthodontic appliances, and at the same time you are injecting parathormone in the surrounding areas, so parathormone is going to resorb the bone, that will facilitate earlier movement of the teeth within that area of the bone, right? So that is again a proven method of accelerating tooth movement. Now we are left with only one option, that is injecting platelet rich fibrin. This is not yet a proven method to accelerate tooth movement. Other than these, there are certain other methods. We have got LIPUS, low intensity pulse ultrasound. That is one method. Then we have got low level laser therapy. We have got laser therapy as well. Then after that we have got a method known as micro osteoperforation, which can also be called as which is basically done by the help of this device called Propel. What you do, it creates very small holes in the surrounding alveolar bone between the two teeth, and all these methods, they make use of a phenomenon known as regional acceleratory phenomena. We have talked about this earlier in my live lectures as well as in the recorded lectures. Now, what is regional acceleratory phenomena? You are purposefully injuring the bone. Also, corticotomy also makes use of this. So, you are purposefully injuring the bone, and upon injury, what happens next? The body undergoes first catabolic mechanism followed by anabolic phenomena, right? So, it increases the bone turnover rate. That means you are purposefully injuring the bone is going to get healed automatically in a very rapid manner. So this rapid acceleration which causes healing of the bone leads to movement of the tooth through the bone, which is done by this method known as regional acceleratory phenomena. Alright. Now next question. A patient presents with mild crowding in the maxillary arch with buccal crossbite from premolar in the left side till last erupted molar. He had TMJ pain with deviation on the left side on mouth opening. Now what shall be the treatment considered for him? Now we are presented with certain application, certain clinical scenario. So this is an application based question. You have to read the question twice or thrice even sometimes, and most of the time, the hint is within the language of the question itself. All you need to do is just read the question thoroughly, if not one time, maybe twice, maybe thrice sometimes, and in most cases you will reach to a proper conclusion yourself. Okay, now we have mild crowding, we have got buccal crossbite, and we have got mandibular deviation along with TMJ pain. Now what should be the proper treatment for him? Options are fixed appliance in both maxillary and mandibular arch, expansion, fixed appliance in the maxillary arch only, and we have pre-surgical orthodontics. Now, among the four options, expansion of the arch is the only valid reason. It's the only valid treatment option in such case. Why? Because the patient is having functional deviation on one side, and functional deviation, to start with, it has led to a development of full-fledged asymmetry in the mandible. That has led to development of TMJ pain as well. So if you expand the maxilla properly, in most likelihood, the functional deviation of the jaws will be corrected by itself. Alright? So expansion of the jaws is the correct answer to this question. Next question. Which movement will be seen if this wire is placed in the upper left maxillary central incisor as seen in this figure? Now the question is asking what kind of movement is going to occur in such cases once you insert the wire in this way. Now first of all, we have to understand what kind of a bend is this. These are artistic bends, right? How many types of artistic bends are there? There are three types of bends basically. First is the first order bend, second order bend, and the third order bend. First order bend, what we do? Suppose this is your molar, upper molar, this is your upper premolar, this is your upper premolar, right? And these are the molar tubes, the bracket and the bracket, right? Now, what are first order bends? They're also known as labiolingual bends, in-out bend, extrusion-intrusion bends, or up and down bends. There are certain synonyms to these bends. So, what are first order bends? This is the arch wire. So, in order to bring this tooth, the premolar little out, as you can see, it is slightly palatally placed as compared to the adjacent two teeth. So, we want the premolar to be brought slightly buccally, intentionally buccally. So, what we do? You will give this kind of a bend in this, right? So, this is going to push the tooth either palatally if we want it to be pushed slightly palatally, or if you reverse the direction of the bend in this way, this is going to push the tooth slightly buccally. Okay, so this is what is known as first order bend. What are second order bends? So these are second order bends. If a tooth needs to be corrected in the vertical plane, that means if the tip of the tooth needs to be corrected, right, we have to give second order bends. So if you give this type of a bend here, as seen in this figure here, so this is going to cause movement of the tooth in such a way it is going to cause uprighting of the root of the tooth, right? So this is going to cause improvement in the tipping movement of the tooth. It is also known as mesodistal bend, angulation bend, or tipping bend. As the name suggests, it corrects the tip of the tooth. That's why it is known as tipping bend. Now, what are third order bends? They are also known as inclination bends or torquing bends. Now, what happens in many times, in many cases, in many clinical situations, we come across a situation where the tooth is like this, okay, and we have to correct the root position of the tooth without correcting the crown portion of the tooth. What we do in such cases? This is the bracket on the tooth surface. Now we want the root of the tooth to be in this position rather than in the above position. We want only and only the root to move slightly distally. So you give a small torque within the arch wire, and then we place it within the bracket slot forcefully, and we ligate it using a ligature wire. So this is going to cause movement of the tooth in such a way that only the root part of the tooth moves slightly distally or slightly palatally, and the crown does not move. In this case, we have talked about this in biomechanics also. In this particular tooth movement, the center of rotation lies at the incisal edge, at the incisal tip, right? So that's how the movement of the tooth takes place in a lingual or palatal direction, right? So this is for correction of the torque of the tooth. That's why the question is asking, it's an image based question, and hence the correct answer will be option C, that is tipping movement of the teeth. Next question, which of the following requires immediate treatment while the deciduous teeth are still in the arch? Immediate treatment means we have to intercept the treatment, we have to intercept the condition as soon as it is observed and as soon as it is diagnosed. Okay, that means we cannot wait until a development of a full-fledged malocclusion in such cases. That is why it requires immediate treatment. Options are deep bite, retruded mandible, anterior functional shift, or midline diastema. Now, deep bite is a self-correcting anomaly, remember, so we can leave it like that. In most cases, in most likelihood, it is going to correct on its own. Retruded mandible, well, we cannot do much about it in the early stages of life because it is also a self-correcting anomaly up to a certain extent. But if the condition still persists, we have to wait until the child obtains a circumpubertal age. That is, until the child obtains the pubertal growth stage. That is 11 to 13 years in cases of girls and 12 to 15 or 14 years in cases of boys. Only then, once the patient is having retruded mandible, class 2 malocclusion, we can intercept the condition using a mild functional therapy. So we don't have to do anything in the deciduous dentition. Midline diastema, again, this is a self-correcting anomala. Why? Because midline diastema could be because of the erupting canines, the erupting maxillary canine, by a process known as Broadbent phenomena. Remember? So all you need to do is just counsel the patient and the patient's parents that this is a self-correcting anomaly. You just have to wait and watch, and it is going to get corrected on its own after some time. But option C is the only condition which needs immediate attention. Why? Because if the patient is having anterior functional shift of the mandible while closing, in most likelihood, this is going to get converted into a full-fledged class 3 malocclusion. And as I have said many times, class 3 malocclusion is one of the most difficult malocclusions to correct later on. So you have to intercept this as soon as the condition is diagnosed, as soon as the condition is caught, right? So the correct answer will be anterior functional shift of the mandible. Next, what should be the method if you want to increase the vertical growth of the jaws while doing orthodontic treatment? So here in this question, we are specifically wanting the vertical increase in the jaws. Like you can say, in what cases do we need increase in the vertical condition of the jaws? In cases where we have deep bite, right? In cases where we have anti-clockwise growth pattern of the mandible, right? So we want the mandible to slightly rotate downwards and backwards so that the vertical facial height of the patient can increase. What do we want to do in such case? We want the upper molar to slightly extrude. So because of that, because of the wedging effect, the mandible is going to rotate downwards and backwards. So that is how it is going to get corrected. The deep bite is going to get corrected. Now, how it can happen? We can do it either by 2-3 methods. What method? Either we extrude the upper molars or we intrude the lower molars. But intrusion of the lower molars is not going to help. Why? Because that is going to further cause the deep bite to deepen. Or if we want to extrude the molars, well, extrusion of the lower molars is not a very stable thing to do. So the most stable and more acceptable method is to extrude the upper molars. Now, in what condition can we extrude the upper molars? Options are functional appliance with bite block, high pull headgear, cervical headgear, and high pull headgear combined with functional appliance. Now, we don't want functional appliance in this case because there is no mention of retruded mandible in the question. Had the question specifically mentioned about retruded mandible, then we would have thought about maybe option D. But since there is no mention of retruded mandible in the question, we can eliminate option A and option D. We are left with two options, high pull headgear and cervical headgear. Now let's take a brief look at the biomechanics of both. In case of cervical headgear, the headgear takes support from the nape of the neck here, and the biomechanics are such that it causes distal movement of the upper molar and exclusive effect of the upper molar, right? It is causing distal movement of the upper molar as well as it is going to cause extrusion effect of the upper molar, and that is exactly what we want. We want extrusion of the upper molar, correct? That is why the correct answer will be cervical pull headgear. What happens in high pull headgear? We are intruding the upper molar, and this is of use in cases of open bite correction. Open bite could be because of excessively extruded upper molars. So we want intrusion of the upper molars to take place, and this is one of the good methods to correct the malocclusion involving anterior open bite because of extruded upper molars. right? So the correct answer in this question will be option number C, that is cervical pull headgear. I hope I am clear here. Next question. The appliance is used for the correction of. It's an image-based question, quite a straightforward one. So for this, you need to identify what appliance the question is asking. So we have FR3. What is FR? It's Frankel regulated 3. Frankel appliance. Why is it third? Because you can see the pellets, the lip pads or the lip pellets are placed in the maxillary arch. If they were placed here, here and here, if the lip pads are placed in the mandibular arch, then we can say that it can be either FR1A or FR1B or FR1C, that is specifically used for correction of the retruded mandible. But in this case, the lip pads are placed in the upper arch. Correct? So we are talking about correction of the maxilla. Correction of the maxilla in the sagittal plane. That is why this is used for the correction of skeletal class 3 malocclusion. We are not talking about incisal compensation or decompensation here. We are specifically talking about correction of skeletal class 3 malocclusion here. A brief introduction about the appliance. So FR appliance makes use of two working principles, that is force elimination and force application. Right? So what are the components of a functional regulator? We have maxillary lip pad, we have lower labial bow, we have protrusion bow, buccal shield, and we have parietal bow. So the buccal shields work on the principle of force elimination. How? Because it is going to shield the teeth from the buccal musculature, from the inward forces of the buccal musculature, specifically the buccinator muscle. Right? So we are shielding the teeth from that, and that shield is used. It is obstructing the buccinator mechanism to work. That is why the buccal pad of the functional regulator works on the principle of force elimination. But the lip pads which are present on the upper teeth, on the labial surface of the maxilla, they are placed high up in the vestibule. As you can see here, this is placed high up within the vestibule. Now this has a unique property. If it is placed high within the vestibule, it is going to cause a periosteal pull. Once this periosteal pull is transmitted to the underlying bone by a mechanism known as transduction, mechanotransduction, right? Mechanotransduction. This is quite a complex phenomena, so let's leave it to be discussed some other day. Just remember the word, what exactly is happening. So the periosteal pull by means of mechanotransduction, this pull is transmitted to the periosteum surface, and this pull leads to tension within the bone. And as we have discussed about in the biology of tooth movement many times, whenever there is tension occurring on the bone, it leads to bone formation, and whenever there is pressure occurring on the bone, it leads to bone resorption. Now because of the periosteal pull, there is tension developing. Because of tension, the bone is going to develop within the anterior surface of the maxilla, and that is why the class 3 can be corrected. Class 3 because of hypoplastic maxilla. That can be corrected by use of by the use of this particular appliance known as FR3, right? And this figure here, it shows that this is the profile of the patient without the appliance in the mouth, and this is the profile of the patient with the appliance in the mouth. You can see a significant improvement in the profile. Why? Because the lip pads here, these lip pads are going to support the upper lip, number one, and over a period of time, because of periosteal pull, the bone will be formed here in the deep within the vestibule. So the maxilla can be shifted slightly anteriorly in the striatal direction. That is going to correct the class 3 malocclusion also. Alright. Next question. The picture is showing a patient with tongue thrusting habit. What features are going to be seen in this patient? So it's an image based question. So we have to remember what are the clinical features of tongue thrusting habit. Let's see. We have upper anterior proclination and spacing. Yes, we can see this. We have deep bite. Do we have deep bite in tongue thrust patient? No, we don't have a deep bite. We have an open bite rather than deep bite. And we have a large tongue, right? Now, as you can see in the figure, this is a condition. This is a clear-cut condition showing a complex tongue thrust habit, having tongue thrusting in the anterior region as well as in the posterior lateral region. So it's a complex tongue thrust habit. It's a combination of anterior as well as lateral tongue thrust habit. So the correct answer is option A, C and D. Right? Because we don't see deep bite in a tongue thrusting habit patient. Simple question. Next, root resorption is accelerated by. Root resorption is accelerated by. Whenever adjacent tooth is extracted, no, I don't think so. It is accelerated. It has no effect on the root resorption. We can eliminate this option. Whenever succeedance tooth is absent, now this is quite a common sense question. You know, if the succeedance tooth is absent, what succeedance tooth are we talking about? We are talking about a permanent tooth, right? So whenever the permanent tooth is absent below a primary tooth, does it cause accelerated root resorption? No, it does not. So we can eliminate this option also. Now we are left with two options: whenever there is occlusal high point or whenever there is inflammation of the pulp. So occlusal high point and inflammation of the pulp are the causative factors for accelerated root resorption by a process known as external apical root resorption. So this is caused by occlusal high point, and whenever there is inflammation of the pulp, it causes internal root resorption. Right? So occlusal high point, whenever there is also occlusal prematurity. Maybe if you have done a restoration using a composite or an amalgam, whenever there are occlusal high points, the patient will experience sharp pain upon occluding the teeth together. So as a good dentist, you are supposed to identify that high point. You are supposed to relieve that high point so that the periodontal ligament does not go excessive stress and it does not undergo excessive inflammation also. So it will not cause any external apical root resorption. But whenever there is inflammation of the pulp could be because of any reason. The inflammation could be because of introduction of any bacteria within the pulp, because of any large cavitated lesion in the tooth, right? Or there could be anachoretic effect on the pulp as well. That is, the infection is somewhere else, and by the means of bloodstream it reaches to the pulp. Although this is quite rare, but it does happen 1 in thousands or 10,000 cases. So we cannot eliminate that possibility as well. So if we have occlusal high point or if we have inflammation of the pulp, there are high chances that the root resorption can be accelerated. So statement number C and statement number D are true. So we are left with only options C and D. So these are the correct options to this question. Next question, again an image based question. We have to identify the appliance. Now what appliance is this as shown in the figure? So this is a pendulum appliance. As you can see, this is a Nance button, acrylic Nance button. We have cemented, we have band cementation on the premolars as well as on the molars. We have got TMS springs which are soldered onto the molar bands. So this is a classic original design of pendulum appliance as given by Hilgers, James Hilgers. Okay. Now just to give you a brief introduction about other appliances as given in the question. What is Jones jig? It is a distalizing appliance. All these appliances are distalizing appliances. Pendulum appliance, Jones jig appliance, even T-Rex appliance also. Whereas Nance button is a anchorage reinforcing appliance. Okay. So Jones jig was given by Jones and White. So it is a buccally placed appliance over the teeth. What happens here? This has a Nance paddle button, and there's a buccal assembly. There's a buccal assembly. You can see here a small spring is wound on that assembly, and this spring is going to move this tooth, the molars, distally upon activation. Alright, so this is the buccal assembly I am talking about. This figure here shows the buccal assembly of the Jones jig. Now what is a T-Rex appliance? It is a modification of the pendulum appliance. It was given by this person called Snodgrass in the year 1996. Now T-Rex, what is T-Rex? That was one of the most ferocious carnivore dinosaur. Everybody must have watched Jurassic Park. It is that this particular dinosaur is the center piece of attraction in the movie, all franchises of the movies. So the T-Rex appliance is somewhat like that only. So it has a Nance paddle button, having a midline split here, and having a jack screw for expansion in the transverse dimensions. Alright, and we have occlusal steps, and we have other appliance similar to that of a normal pendulum appliance. Okay, so that is called a T-Rex appliance. Right, there's another appliance called PHT appliance. The only difference between PHT appliance and the T-Rex appliance is in the PHT appliance there is no acrylic. There's no acrylic at all. In the PHT appliance, there's no acrylic. Whereas in a Pendex appliance, there is one more appliance called Pendex. All these appliances are modification of pendulum appliance only. T-Rex, PHT, Pendex appliance. The difference between Pendex and the T-Rex is that you can see here in the T-Rex appliance, you can see that the molars are connected with the help of this stainless steel bar. Later on it can be disconnected. You just have to section this band, you just have to section this wire, and the molars are free to move distally. But in a Pendex appliance, the molars are not connected. Rest of the appliance design is exactly similar to that of a T-Rex appliance. Anyways, don't go into much detail. This is just for the information that what are the different modifications of a pendulum appliance. I hope you will not be asked such difficult question in the exam, but I have seen one question. There was a particular question which was fast back appliance. I think it came in the last year's INI CET. I think in May, last year May INI CET, this was an image based question. So let's hope you are not asked any more such question, because it's really difficult to identify the distalizing appliances for a UG level. Even I find it difficult. Even today, I find difficult what appliances what. So let's hope such questions are not asked next time. The counteracting torque for bodily translation of the following tooth will be. Bodily translation means we are talking about bodily movement of the tooth. Now in this question, this is again an application based question. So the figure is saying that the forces are applied. Suppose this is the orthodontic bracket. The force is applied at a distance of 10 millimeters from the center of resistance. Alright? Right? And 120 gram of force is applied. Now since the force is applied at a distance away from the center of rotation of center or center of resistance of a tooth, there is a physical quantity which is developed known as moment. What is moment? Force into perpendicular distance. Correct? Now force is how much? 120. Distance is 10. So the moment will be 1200 gram millimeter. This is the moment. But the question is asking counteracting torque, counteracting moment. You can say counteracting moment also. Now one thing to remember here, that whenever force is applied, the moment is generated in a clockwise direction. The moment is generated in this direction, in a clockwise direction. But the question is asking counteracting torque or counteracting moment. The counteracting moment will be generated in a anti-clockwise direction. Simple. That is why once the moment and the counteracting moment, they nullify each other, they cancel out each other. That's how the tooth is going to move in a straight line manner. That means the tooth is going to move in a bodily fashion. Right? So the answer will be, as I said, the moment will be in an anti-clockwise direction. So the answer will be 1200 gram millimeter in anti-clockwise direction. Right? Now this is what is called moment of the force. As I said, moment is the force into perpendicular distance. This is the force, this is the distance. So moment will be force into perpendicular distance, gram millimeter. Right? And the counteracting moment will be in a counteractive direction for a bodily tooth movement. Next question. A patient reports with the following malocclusion. This is again an application based question. Just listen to the question properly. The upper right lateral incisor is in a crossbite with insufficient space and there is unilateral posterior crossbite. What is the best indicated treatment of the problem? So upper right lateral incisor is in a crossbite with insufficient space and there is unilateral posterior crossbite. So there is one clinical scenario, second clinical scenario. Just visualize what, as an orthodontist, what you can do. Options are Hawley's appliance with Z-spring on lateral incisor with canine retractor, Hawley's appliance with anterior midline maxillary expansion and Z-spring for the lateral incisor, Hawley's appliance with Z-spring for lateral incisor, and Hawley's appliance with maxillary expansion and Z-spring for LI, that is Z-spring for lateral incisor and posterior bite plate. Now out of the four options, option D seems to be the most appropriate to be used. Now let's see how. The question is saying the upper right lateral incisor is in a crossbite, right, with insufficient space, and there is unilateral posterior crossbite. So whenever there is crossbite, whenever there is unilateral posterior crossbite, what can we do? We can go for expansion, number one. Alright, so we have got option B and option D. Right? Now we have Z-spring for LI, Z-spring for the lateral incisor, because we want the crossbite to be corrected in a proper way. So we want to have a Z-spring for the lateral incisor, and also there is posterior crossbite. So we want the occlusion to be free. So for that we need a posterior bite plate as well, at least on one side, right? So that is why this option will be option D. The correct answer will be option D. So this is what the question is saying. This is the clinical scenario of the question. You can see there's a posterior crossbite on one side, unilateral crossbite, and the lateral incisor is in a crossbite. So as you can see, this is a Hawley's appliance with Z-spring on the lateral incisor, a midline expansion screw, and a posterior bite block on both sides. Alright, so this is what you need to understand. You have to understand what the question is asking, and as an orthodontist, how you are going to treat that particular malocclusion. What's the purpose of using these elastics in the orthodontic appliance, orthodontic treatment? This is again an image-based question. Now, if you look at the figure, you can see that the elastics, these are intraoral elastics, they are running from from canine of one end to canine of the opposite lower end in a diagonal manner. So these are diagonal elastics. What are these elastics used for? As many of you could have guessed by now, these are used for correction of mild midline discrepancy. Right? How will it work? It is going to move the upper teeth in this way and lower teeth in this way. So this is how it again makes use of reciprocal anchorage, which is used to correct the midline discrepancy in the frontal plane. What are different types of intraoral and intermaxillary elastics? We have got class 2 elastics. We have got class 3 elastics. These are all intermaxillary elastics. All of these are examples of Baker's anchorage, right? Then we have got oblique elastics, as was given in the question right now. Then we have got cross elastics for correction of posterior crossbites, single tooth crossbites. Then we have got box elastics for correction of open bite, box in the form of rectangular box, upper and lower. Then we have got M elastics in the direction in the configuration of letter M. We have got W elastics opposite to M, and we have got triangular elastics in this way. So this one, and this one can also be known as settling elastics. So these are used in the later part of the treatment whenever settling of the occlusion needs to be done after labeling and aligning, and even after correction of the spaces, even after retraction is completed. So in the final stages of treatment, that is called finishing and detailing, these settling elastics are to be used in almost every patient. Identify the type of tooth movement shown in the figure. Right? This is again a very similar question as we discussed earlier. You can see this is a force acting on the tooth, and suppose the center of resistance is here. So this is going to cause a movement in a clockwise direction. As I said earlier, this is going to cause a movement in a clockwise direction. But the figure shows that a counterclockwise movement is also generated at the same time. This is the counterclockwise movement. So the correct answer out of the following options are bodily movement. It is going to cause translation of the tooth in a straight line. Okay. Now this figure shows the center of rotation in uncontrolled tipping, the center rotation in a controlled tipping. The center of rotation is at infinity in case of a bodily tooth movement, and center rotation is at the incisal edge or at the bracket point in cases of torquing tooth movement. Okay. Next question. What will be the retainer of choice for an adult patient who was treated for a 4 mm midline diastema correction? Now, why do we need retainer in the first place? Because whenever the teeth are moved in a direction away from the natural direction, there is a tendency for the transeptal and the dentogingival periosteal fibers to pull the teeth into the original place. So that is a primary cause of relapse after the treatment. So in order to allow the collagen and elastic fibers to reorganize over a period of time, it takes quite many months to reorganize. So during that time, we have to give retainer to the patient. So that will keep the position of the teeth where they are. They are not going to cause the movement of the teeth in an undesired manner. So the retainer of choice for an adult patient who was treated for midline correction will be a lingual bonded fixed retainer. Beck's retainer, removable Holly's retainer, and no retainer are out of question, although they can be given, but we are talking about a better choice of a retainer, and none other than fixed retainer is a better choice, especially for a midline correction, midline diastema correction. So these are different types of retainers. We have got a Holly's removable retainer, We have got a wrap around retainer, Beck's wrap around retainer, right? Then these are the few examples. This is a bonded retainer. As you can see, this was done by me in one of my patients. These are the bonded retainers which are applied, which are pasted on the lingual surface of the teeth. This is a wrap around retainer, Holly's retainer. Okay. Again, these are the two Holly's retainer. These are the appliances I made by my own hands, just to tell you, just to give you an impression. Nowadays, a new type of retainers have come. These are called Essex transparent retainers. They are very similar to the aligners. The only difference is that they don't cause any active tooth movement. They are very similar to aligners, but they don't cause any active tooth movement. Very comfortable to wear. The patient does not feel that he or she is wearing anything, and very effective also. Alright? And these are Holly's retainers. Again, made by myself. Now the next question. According to cephalocoil gradient of growth, what is the ratio of head to the body in adults? Now what is cephalocoil gradient of growth? As you know already, there is an axis, there is a gradient of growth from the head to the toe, right? Now, as you know, once the fetus is within the mother's womb, mother's uterus, the head occupies almost 50% of the entire length of the body, as you can see in this figure. But at the time the child is immediately born, when the child is a newborn, the head occupies almost 25% of the entire length of the body, meaning that the rest of the body has grown more as compared to the head. Then at 2 years of age, the head comprises around 23%. Then at 6 years of age, it reduces to 20%. At 12 years, it reduces to 18%. And by the time the child is an adult, by 20 to 25 years, it reduces to 12 to 13% rather. So the meaning of this is, the implied meaning of this is, as the child grows, there is a gradient of growth from the head to the toe. That means the lower extremities, the lower part of the body grows at a faster rate as compared to the upper part of the body. What can be the other interpretation of this phenomena? That the structures of the body which are closer to the base of the skull, they grow at a, which are, again listen to me carefully, the structures of the body which are closer to the base of the skull, they grow at a lower rate as compared to structures distant to the base of the skull. Now if you take an example, your lower legs are lengthier as compared to your hands, right? Your torso, your trunk is little shorter as compared to your lower legs. So the lower legs are distant from the brain. The torso is little closer to the brain. And if you look at the head and neck also, the maxilla is closer to the brain, the mandible is little away from the brain. So, according to Scammann's growth curve also, the mandible has a tendency to grow later on at a rapid rate as compared to the maxilla. Although both jaws are growing, maxilla is also growing, the mandible is also growing. But the mandible is growing at a little rapid rate as compared to the maxilla because of the phenomena known as cephalocoil gradient of growth. Clear? So the correct answer will be 0.12 or 12%. You can also write it as 12%. So that is all for today. I hope I have cleared a few doubts of yours. So I just hope you will study well, because exams are just around the corner. It's a winter season, especially for people in North India and also for South India also, but especially for North India I'm talking about. You people have to take good care of your health, because the entire country, the northern part of the country is gripped with cold climate right now, and there are chances that because of the changing season, you might catch influenza, cold, and even the newer variant of COVID-19, that JN1 variant which has come up recently. So I hope everybody will be taking good care of yourself. Till then, until next time, all the best, study well, take care of yourself. Okay?